Good morning. Now, I'm acutely aware that I stand between you and coffee, and that this morning most of us need coffee more than we have done on any other morning, so I'll try to keep this fairly clear and concise. So I'm going to give you a quick clinical case history just to put this into a little bit of context and go through some background of valve disease in terms of the size of the problem, and then look at regurgitation and stenosis individually, particularly the natural history and assessment of those, before going over the UK approach to valve disease in aircrew and just highlighting some difficulties that we have with assessing valve disease in our population. So this, as far as I'm aware, is not set up for your clickers, unfortunately, but this is my question, and you might just like to bear this in mind as I go through the presentation. So the risk assessment of UK aircrew with valve disease may involve the use of transthoracic echocardiography, transesophageal echocardiography, cardiac magnetic resonance imaging, cardiac CT scanning, or all of those. So our case history involves a 26-year-old male who had an incidental finding of a murmur on a routine medical examination, and he was referred to us at RF Henlow at our clinical aviation medicine service for further assessment. He was an extremely fit individual and entirely asymptomatic, and ran significant distances, including marathons. Had no past medical history or family history of note, was a non-smoker on no regular medications. On examination, he had a normal heart rate and a normal character of his pulse, but was noted to have a wide pulse pressure with a blood pressure of 176/80. And on auscultation of his chest, he had a long murmur heard throughout diastole. These images are his echo that we carried out. At the top left, you see a parasternal long axis, which shows his ventricle works nicely. He's got good ventricular function, but actually when it was measured, it measured rather large. The top right panel shows his aortic valve in cross-section. It's not particularly great view of it, which isn't uncommon on echo, but it does look abnormal, take it from me. And the bottom left, similar to Matt's picture that you saw earlier, there is a large jet of regurgitation coming back into the ventricle in diastole. And the bottom left panel just confirms that it is throughout diastole with milder forms of aortic regurgitation. You can see it just occupying part of diastole, but the more severe it gets, the longer that regurgitant flow goes on for. So his examination and his echo findings confirmed severe aortic regurgitation with a dilated left ventricle, but which worked normally. He had excellent exercise tolerance on the treadmill, as you might expect of somebody who is a distance runner, and he was subsequently started on an ACE inhibitor and was referred to our National Health Service cardiologists who subsequently arranged for him to have a cardiac MRI scan because they were particularly interested in looking at his valve structure, because he had a very kind of abnormal appearance of his aortic valve, to quantitate more clearly the severity of his aortic regurgitation, look at his left ventricular volumes, and also to look at the morphology of his aorta, because there was some query as to whether or not he might have marfanoid appearances on his echo. His MRI confirmed him to have bicuspid aortic valve with severe aortic regurgitation and a calculated regurgitant fraction of 50%. So half of the blood that was ejected from his left ventricle in systole flowed back the other way during diastole. He had no stenosis and had mildly increased left ventricular volumes with normal function, and his aorta was also normal. And that's obviously important because alongside bicuspid aortic valve, as we heard from Stefan yesterday, there are concerns about aortopathy and dilated aortas, and also the possibility of aortic coarctation. So these are his MR images. Just to show you some pretty pictures. I'm an imager, so I like looking at these, but I won't bore you with any of the technical details. But the top right panel is us actually looking at the flow, and on MRI we can very clearly and confidently quantify the volume of regurgitation, which is important in terms of looking at outcome. There's increasing data to suggest that accurate quantitation in regurgitation relates to your long-term outcome, and it can actually be extremely difficult and very complicated to do that using transthoracic echo. So, valve disease in our population. Well, the first thing is that it's really difficult to know how big the problem is. We don't know that these people have valve disease unless you screen all of them. Being confident that you are able to pick up valve disease, even if you do screen them, is not necessarily straightforward. I'm going to be talking mostly about left-sided valve disease, and Fabio after the break is going to give you some details about right-sided valve disease. But certainly in clinical practice, that left-sided valve disease forms most of what we see, and certainly most of what we actively treat. But valve disease is asymptomatic until late stages, and really once you've got symptoms, then there is a significant potential for you to have already damaged your heart, and so we want to catch it earlier than that. And clearly from the point of view of risk assessing our aircrew, then we definitely like to pick it up before it gets severe enough to cause symptoms. Unlike most areas of cardiology, valve disease is really very poorly understood. We don't know much about the pathophysiology, as I've already alluded to. We don't know much about the epidemiology of it, and the natural history of it is also poorly understood. But clearly the hemodynamics in young and active people, such as we may see, are different from the older, more sedentary population. So although the burden of degenerative valve disease is recognised as lying in older patients, how it may progress and manifest itself in them is likely to be different from ours. And we have to consider on top of that what the effects of G may be, how pressure breathing may affect the hemodynamics and therefore the progression of disease. And these are things that clearly you don't have to think about in most of the civilian population. So to go over a little bit about regurgitation, it's of concern to us because of its association with arrhythmias, which may cause sudden distraction or incapacitation. And in mitral regurgitation, where the regurgitant jet goes back into the left atrium, it causes the left atrium to stretch, and that increases your risk of atrial fibrillation. And then arrhythmias are a particular concern. The extra stress on the left ventricle associated with an increased end diastolic volume causes left ventricular dilatation over time and impairs long-term the function of the left ventricle, and it's trying to pick up valve disease before it gets to that stage and to treat it that we're aiming to do. Structurally abnormal valves are known to be associated with an increased risk of endocarditis, which can have devastating effects. And as I've already alluded to, what are the effects of the unusual circumstances which our population are subjected to, and how does that alter their natural history? And clearly the aorta and bicuspid aortic valves is an important factor, because again, pressure breathing and sustained G may all be important if you've got an aortopathy and an increased predisposition to aortic dissection. But predicting outcomes is difficult as risk factors are poorly defined, and this is even more so in our younger population. The progression of regurgitation relates mostly to severity, but the caveat to that is that very little is known about milder forms of the disease. And in fact, mild regurgitation is, in many circumstances, regarded as acceptable or physiological. And in fact, until relatively recently, the term physiological regurgitation was in some of the guidelines for the assessment and management of valve disease. As Ed said earlier as well, our technology is improving all the time. So what we can detect now using colour flow Doppler is not the same as it was even 10 or 15 years ago. So we don't know whether this has been there all along, whether mild forms of regurgitation are at exactly the same levels as they have been previously, but we just weren't able to see them, or whether in fact we are seeing something that is pathological in the long term. As the regurgitant volume, or the size of the regurgitant orifice, increases, progression does become more likely and more rapid. And the more severe your regurgitation, as I said, the greater the burden that it places on your left ventricle, and you increase your risk of symptom onset as your valve disease becomes more severe. The assessment of regurgitation really relies on good imaging and good interpretation of that imaging. So you have to have faith in your, most commonly in your echocardiographers, that they are acquiring adequate images, and that in our practice, in fact, it's our technicians who read our studies, although obviously that's different to how it is in other countries. But if somebody else is reading your studies, you either need to be sure that they are interpreting those images appropriately, or have access to that imaging yourself so you can read it and make your own interpretations. Now, in regurgitation, the hemodynamic conditions at the time of the images are really important. It's very well acknowledged that if you decrease someone's blood pressure and decrease your afterload, then in fact your regurgitation, which may be severe under normal circumstances, can almost disappear. And the classical example of this is on transesophageal assessment of mitral regurgitation, where given sedation, the patient's blood pressure may drop a lot, and so their severe regurgitation seen on transthoracic imaging may pretty much disappear and just be a trace or very mild mitral regurgitation at the time of the TOE. And detailed quantitation may be useful. As I've said, MRI is very good at doing this, and there are more data emerging to suggest that quantifying it accurately can help you to predict the long-term outcome for patients. And also, when we image, we're looking at the left ventricular response to regurgitation. It's not just whether it's mild, moderate or severe, but it's what does the ventricle look like. And it's not unknown for the left ventricle to look disproportionately dysfunctional compared to the degree of regurgitation, and that may lead us on to do further investigations to decide whether or not there's actually an underlying cardiomyopathy alongside the valve disease. Transesophageal echo and cardiac MRI can also very carefully look at the structure of the valve, and that's not always clear on transthoracic imaging, certainly on 2D imaging, although again 3D echo in the right hands with patients who have optimal body habitus, as most of our patients will do, gives us very good information as well. So for stenosis, the vast majority of patients we talk about will have aortic stenosis, and in our population, a patient who has aortic stenosis is relatively more likely to have a bicuspid aortic valve. Obviously, there is the age-related degenerative calcific aortic stenosis that we see in older populations, but for us, it does mean that there is a relatively high likelihood of bicuspid aortic valve. And as I've said, that's associated with aortopathy and coarctation, which in our patients may be more significant for their risk and management, and those will need to be assessed in their own right. And it may be that in fact the aortopathy, particularly with the dilatation, may become the overriding feature, and that may influence their outcome more than the associated valve disease. Mitral stenosis, clearly we don't see very often because it is almost always going to be associated with a previous history of rheumatic fever, which for us is uncommon. But there will also often be other associated valve lesions in that case. Again, stenosis, the natural history is poorly understood, but essentially any degree of stenosis is considered abnormal. We can see what we refer to as aortic sclerosis, which is largely accepted as being a thickened or calcified or abnormal looking aortic valve, which doesn't have significant narrowing, so the blood flow across the valve is not accelerated. Once the blood flow, once the pressure gradient across the valve increases above the normal threshold, then we class them as having stenosis. The altered hemodynamics going across the aortic valve essentially potentiate the underlying pathophysiology, and those abnormal stresses across the valve will continue this kind of cycle of dysfunction and will cause further deterioration in the function of the valve, and therefore the valve disease will progress. Development of symptoms or adverse outcomes very much predicted by your severity, and the rate of progression will also relate to your symptom onset and need for surgery. And in patients who have a rapid increase in the gradient across their valve, they are much more likely to go on to need surgery in a short period of time or to develop symptoms than those who have a slower rate of progression. So again, assessing stenosis relies on good imaging, but is less sensitive to changes in the hemodynamics. That said, because of the ways in which we measure it on echo, then there is significant risk of error because of the calculations involved if the various measurements aren't made accurately. In most patients, quantitation will be straightforward with transthoracic echo, but assessment of the valve structure, particularly in a heavily calcified or abnormal looking valve on transthoracic echo, can be very difficult to decide whether or not it's a bicuspid or tricuspid valve, especially when the patient's got a prominent raphe, as Stefan talked about yesterday. It can appear to be tricuspid when in fact it's bicuspid. And so therefore using cardiac MRI or cardiac CT scanning in some cases can allow us to have a better look at the valve structure. And as I've said, the rate at which the gradient across the valve increases allows you to predict the rate of progression. So what do we do in the UK with these patients? Essentially, people who are known to have valve disease applying to become aircrew, we don't let them in. But in those who have mild regurgitation alone, once they are in service, then we don't put any specific limitations on them, but we'll continue to monitor them. If you have any degree of stenosis, or if you have more than mild regurgitation, then we make them unfit solo flying, and they have to fly as or with. They're also regarded as being unfit strenuous physical exertion and unfit sustained acceleration. But if they progress, and once their disease becomes more than moderate, then we ground them. But as I've said, there are difficulties associated with this. We need to be confident when we're assessing them and confident in the quality of imaging. And we're very fortunate in that at Henno we undertake our own imaging. So if we're unsure about what the reports might be from our civilian hospitals, then we're able to confirm those and document what the valve looks like and also document progression for ourselves. There's quite a grey area when it comes to mild to moderate regurgitation. Like most things in medicine, it's not absolutely black or white all the time. And so when we have someone who's got features of moderate regurgitation, then it may be that although overall things appear mild, some of their measurements would put them into the moderate category, and then it becomes slightly more difficult to decide how we restrict them. And what do we do about aortic sclerosis? As I've said, they've already got essentially an abnormal valve, and that as the flow across that valve potentiates their underlying problem, then it may well progress. Then, should we be keeping an eye on these people? Well, again, doesn't cause symptoms, doesn't cause anything that you would find on examination. So how do we know it's there? And it's also established that aortic sclerosis itself is associated with adverse cardiovascular outcomes and also associated with TIA and stroke. So that's a quick overview of valve disease and how we deal with it. So this was the question I posed at the beginning. And it's now gone into the system, so you will be able to vote shortly. Okay, so when we're assessing valve disease in the Air Force, do we use transthoracic echo, transesophageal echo, cardiac MRI, cardiac CT, or all of the above? Vote now. The longer it takes you to vote, the longer it's going to be before you get your coffee.
That's got to be a good incentive. We must be able to get up to 50. We were up at 71 last time. You don't have to worry about embarrassing yourself. We can't track who's not working. Oh, okay. Some are working, some aren't in that case. 50.
Yay. Yeah, we use all of those in different circumstances. Obviously, the majority of the time they will get a straightforward transthoracic echo, and that may well be all that we need, but we certainly use the other modalities when necessary to make a full assessment.
Thank you very much.